keep with the theme and walk through the organs, we're now on the thyroid. But there was a question at the break, which is a good question. So I wanted to pose it to all of you. So if the body's making too much growth hormone, and the hormones bind to the receptors and they saturate, how is it that overproduction of growth hormone is going to cause gigantism or even acromegaly? What else has to happen in addition to growth hormone being upregulated? Upregulation of the respective receptor. Okay? So the opposite scenario can take place with growth hormone as well. You could have an individual that's, and now there's a clinical term for it, it's called short stature. Okay, so short stature is an individual who doesn't have a chondroplastic dwarfism, meaning they're proportioned, but I think there's a clinical cutoff, like, less than 5 feet or something like that. Okay, and so it's called short stature. 10 years ago, the term didn't even exist. Okay, so wow, is this a disease? No, it's just saying that that individual is shorter in size. Now, what could happen is, and you also have tall stature, but we don't call it that, right? So there's a lot of people that play basketball, and they're really, really tall. Okay, or women that play volleyball, and they're really, really tall. So what's going on in those two extremes? An individual that's less than 5 feet in size, an individual that's actually larger, taller than 6'5", 6'6". Well, there probably is this underproduction of growth hormone in the short stature individuals, or they can have sort of relatively normal production of hormone, but low number of receptors. And the polar opposite is true in the tall individual, where they make more growth hormone than the average individual, but they also have more receptors for those hormones. Okay, and so we have this range, but we're talking about stuff that's pathologic. We're not talking about stuff that's someone's kind of short or someone's kind of tall. That's kind of in the normal population. So we don't really cover those kinds of things like short stature or somebody that's 6'10", which is really tall. Okay, and someone that's 4'6", that's rather short. But that's within the normal physiology. You guys with me? We're talking about pathological conditions that are caused by some underlying disease state. And so, for example, like I have a daughter who, my kids are pretty short, and I have one that's really short on the growth charts. And so she was diagnosed with the short stature thing, and my wife and I went through all these tests and stuff. Of course, we discovered that she's completely healthy, which we were very, very grateful for, but we felt like we needed to do that because the doctors were telling us that she wasn't growing at the same rate as the other kids in the class. But at the end of the day, we discovered, no, there's nothing pathologically wrong. It's just she's, on the short end of the spectrum. And you look at me and you're like, yeah, I could have told you that, man. Right? And this is like a pediatric endocrinologist. My wife and I are standing there, and we're like, actually, this endocrinologist was shorter than me. It was kind of funny, and talking to us about growth rates and stuff. But and then we said, and her my mom peaked at like 4'11", right? That was like her. So my mom's about that tall. So when we give her the family history, then the endocrinologist, the pediatric endocrinologist, so well, it does make sense, but it's important to make tests, make sure there isn't something wrong with hypothalamus, there isn't something wrong with the pituitary. Make sure that even the thyroid is not affected, because metabolism can have a role in that too. So I don't want to get overly complicated, but if metabolism too low in an individual, they may not be growing either. So anyways, that was a good question that made me think I better stop and pause before we move on and talk about how we have these activities. If we look at hyperthyroidism, as we continue this theme, this is also called thyrotoxicosis. The issue is too much activity at the level of thyroid. Now, Graves' disease is something you've probably heard of. This is a type 2 hypersensitivity where the thyroid is overactive, and that's caused by these autoantibodies. We looked at that. And they activate the receptor. And so that's a common cause of it, is Graves' disease. Or it could be a toxic goiter, a nodule. A goiter is a swelling of the thyroid gland. That's the general terminology of what it means. And so as the thyroid gland enlarges, it is overactive. Or this could be an adenoma, a lesion at the level of the thyroid. And you might know a friend or a family member that had a hyperactive thyroid and had to have the lesion taken out, and maybe that's all that was necessary, or they had to have the whole organ removed, and now they're probably on a thyroid supplement, a thyroxane supplement. So thyroxane is T4, and T3 is 3 to 4 times more active than T4. And the secondary effect could be too much thyroid stimulating from the anterior pituitary. So here's a perfect example of the access question I could ask next week. If a patient has hyperthyroidism, which of the following could be the cause? You ready? An adenoma that's functional in the thyroid. An adenoma in the pituitary, the anterior pituitary, that's causing hypersecretion of TSH. Both of those would be correct answers, right? Okay, so that would be the A and B only option. Then I'll give you like C and D that are like totally out in the left field. Okay? All right. Now, if you look at this patient in the upper right, you can see the date here, July 7, 2008. This patient was suffering from thyroid toxicosis. And one of the things that we can do is we can treat with a drug that is a thyrostatic drug. And the drug here is called carbimazole. C-A-R-B-I-M-A-Z-O-L-E. And so you can see the result of this drug treatment is pretty dramatic. Okay? So the thyroid controls metabolism, and you can see if the thyroid is too active in the upper right picture, and you can see about 5 months later, so December 29th, so it's month, or it's day, month, year. So the 29th of December in 2008, so about 5 months later, a little bit, about 5.5 months later, this individual, your scale bar is actually this little necklace. You see the little necklace that he has? That tells you the relative scale of the arms and of the clavicle bone, and you can see the neckline. So they had dramatic improvement by just calming the thyroid down a tad. Okay, carbimazole, a thyrostatic drug. If we look further at Graves' disease is one of the most common causes of thyroid toxicosis. And in this situation, you make autoantibodies to the TSH. We talked about that before. Those autoantibodies to the TSH stimulate the receptor to make it active, even though TSH isn't being produced. Some clinical features. You've got hyperplasia, or excessive cellular growth of the thyroid. You have hypertrophy, enlargement of the thyroid. You have this dermal pathology, where you get these sort of rashes that take place on the tibial crest. It's actually rather rare to see that, but I showed you a picture right here of what that looks like. And then you get this eye disease, ophthalmos. This eye disease, which is kind of these bulging eyes that take place in these patients, along with excessive weight loss. And you saw that in that previous patient. The excessive weight loss is because the metabolism is so high. So here's a picture of an individual with Graves' disease. This exophthalmos is this eye disease, this bulging eye symptom. And this is the same exact figure that we looked at when we were talking about type 2 hypersensitivity. We're looking at TSH and the antibodies that are manufactured toward the receptor, causing it to be stimulated. so that's the metabolic disruption. Some other clinical sequelae: an increase in basal metabolic rate, an increase in heart rate, difficulty sleeping because your heart's racing at night. It's hard to kind of calm down and relax. And then this exalphalmus, this eye disease. Hyperthyroidism. Now we can look at hypo. Like with hyper, if you have weight loss, if you make too little of the thyroid, what do you think the result is? Weight gain, okay? Metabolism slows down, lethargy, difficulty staying alert on task, okay? Students might see grades dropping because their attention in class, it's hard for them to focus. They drift off, or they're just, they're not alert, okay? All of these kinds of things could be a result of hypothyroidism. This one is the most common malfunction of the thyroid. So Graves' disease is one of the more common ones for hyper, but of the thyroid itself, it's most likely going to be hypo than hyper, numbers-wise. Okay, so this is the most common type of thyroid problem or malfunction that we see. The autoimmune disease here, there are anti-thyroid antibodies. Not TSH, these are anti-thyroid antibodies against the thyroid tissue itself. Or thyroiditis, which is a bacterial infection of the thyroid. Or it could be an endemic goiter. This is a different type of goiter. Goiter is a word that just means enlargement of the thyroid. Before we saw that because it was overactive. Here we see an endemic goiter as a result of dietary problems. Okay, so these endemic goiters that happen typically in third world countries, we don't see it much in the United States anymore, because back in the 1900s, the Food and Drug Administration decided to do something about this problem so that we didn't have an issue, because we are getting very low amounts of iodine in our diet. Foods that are high in iodine are seafood, like tuna and cod, seaweed, eggs and milk. Okay, so if you don't have access to a lot of these foods that are rich in iodine, and those are not inexpensive food sources, right? It's really hard to get seaweed in Flagstaff, just in case you're curious. But all these other foods are actually not, they're sort of costly. So what did we do? Where did we put a supplement of iodine? Salt. Okay? So iodized salt is where we get that. So outside of the U.S., it's more common that we have these endemic goiters because of dietary problems. In fact, over 90% of the cases worldwide of this endemic goiter are a result of iodine deficiencies. Okay? It's also kind of cool, diagnostically, just so you know, if you have adenoma of the thyroid, and you go in and you cut it out, the prognosis is very good of survivability with thyroid cancer or thyroid adenomas. And here's why. We can radio-label iodine, and the only tissue that takes up iodine in the entire body is the thyroid. So if you have a tumor of the thyroid, you cut the whole organ out, you give the patient radio-labeled iodine water to drink, you wait a couple hours, and then you image the neck. If you see anything, you got to go back in and cut more out. If it's clear, you got it all. Does that make sense? So the prognosis for thyroid cancer is actually really good. It's one of the most highest survivability rates of all cancers because of this little fact about the tissue taking up iodine. And then we can cleverly radio-label it, make it radioactive, iodine, consume it. You're like, is that a good idea? Well, it's just short doses in a short amount of time. And you can take a picture and see if it's still there. And then anti-thyroid drugs. So in the previous patient, right, if you over-treat with a thyrostatic drug, like carbimazole, and you do too much, you can actually swing it the other way. So we have to dial in the patient sometimes and kind of reduce the dosing if they're hyperthyroidism, so you don't make them hypo. Make sense? And of course, that can be a difficult process because when they go from hyper to hypo, it's like they can't sleep at night, now they can't get up in the morning. Okay, and you put them the other way, their heart rate races again, and so they're kind of dialing in until they get it just right. Okay, so that can be a little bit frustrating for patients or their family members. So just keep an eye on that. Secondarily, those are the primary causes. Secondarily, it could be a congenital defect where the thyroid doesn't grow or develop to the full extent, or secondary could be a side effect as a result of surgery. So cutting out a thyroid tumor, right, especially if the whole cancer affects the thyroid, you remove the whole thing, the patient without supplemental thyroxine is going to be hypothyroid. So they'll be taking a little pink thyroxine pill every morning with the appropriate dose. For children, it's about 25 micrograms for pediatric patients, and then for adults, it can be up to 100. Okay. All right. Another very common, or a common cause of hypothyroidism is known as Hashimoto disease. This was discovered by a Japanese physician many, many years ago. This is dating to the early 1900s, like 1912. And with Hashimoto's disease, you've got an attack using CD4 cells and CD8 cells that actually destroy the thyroid tissue. Hashimoto's disease. So this is an autoimmune disorder that specifically sensitizes the T cells. Here's the helper T cell that's been sensitized to the thyroid epithelium. And these helper T cells of the CD4 positive family, through the activity of the release of gamma interferon, stimulate activated macrophages to come in and actually cause damage. In addition to that, they activate cytotoxic T cells, or CD8 positive cells. So it all hinges on the helper T cell. And the third activity is creating autoantibodies with Hashimoto's disease. Okay, so you've got sort of three activities rendering the thyroid essentially useless with this autoimmune disorder. So we talk about autoimmunity first, we talk about cancer, and then we talk about endocrine dysfunction, because those are the main causes of endocrine disorders. Now, hypothyroidism clinically, here's what it's going to look like in children, pediatric case. This is a congenital hypothyroidism, and the word that we use to refer to this is cretinism. Cretinism is congenital hypothyroidism in children. So like with growth hormone, we had giganticism and acromegaly happening really around the same hormone problem. That's what's happening here, but we have a special term when we talk about pediatric cases. So the symptoms here, this is the list that we actually gave earlier. They're cold intolerant, meaning that they run low on body temp because their metabolism is slowed down. Okay, so they can't handle the cold very well. They have very little energy, so they're listless. They gain weight instead of lose weight. They have a lot of edema, fluid collection. They're constipated because things aren't moving correctly or as fast. They can actually develop pericardial effusions and even progress into heart failure because that fluid is sitting around creating what we call a cardiac tamponade. Now, if you look at this patient, the image caption here, on the left, the untreated state, this is a 10-year-old girl with severe cretinism, primary hypothyroidism. And she was, at 10 years of age, her bone age, according to her growth plates, was 5. She hadn't lost a single tooth at 10, chronological age. Okay? After treatment with thyroxine, in 10 months, she lost 6 teeth. She had a striking catch-up in weight, or in size. The bone age grew and caught up, and you can see the kind of the before and after, or the untreated on your left and the treated on the right. Okay? Now, in this case, the diagnosis would be measuring thyroid stimulating hormone. thyroid stimulating hormone. Why? I'll pose the question, why do we look at TSH here? It's not the only thing that we look at, but the confirmation diagnosis would come by understanding what's happening with TSH levels. Any clues here? Okay, so this is an axis type of question, right? So if you have low TSH levels, then the thyroid is likely going to be overactive. Okay? So you have a hyperthyroidism. So less TSH levels being released by the anterior pituitary is an effort to control the thyroid hormone levels. So you look at diagnostically what's happening at the level of hypothalamus and what TSH is being released. Okay? Let's finish up with the pancreas and diabetes mellitus. So I said that diabetes was Latin for what? Siphon. And mellitus is what? Sweet like honey. It's like a term of endearment. Okay? So mellitus has to the salt basically. Okay? I think it's kind of a sweet name, but we don't really speak much Latin outside of this classroom. So sweet like honey. So we're siphoning sugar, glucose. But the way that this was diagnosed a long time ago, right? This is at the time of the Greeks and the Romans, when we were kind of looking at original medicine, Western medicine, if you will. What would they do? Do you know how they would diagnose a patient with? What's that?
They would taste the feet.
They would either, I mean, you might have been a practice that tasted the urine, but I'd probably just smell it. No, but you're right. You could either taste it or smell the sweetness from the glucose in the urine.
Or on the breath.
Okay, or on the breath. We'll see some of the differences. A lot of that's due to ketoacidosis, but this is where this terminology originally came from. Okay, so type 1 versus type 2 here, and we're going to make it very, very clean in today's lecture. Okay, so this is where we get some of the extra slides were cut out just to kind of hone in on the topics that I think are most important. So the inability to produce appropriate levels of insulin is type 1 diabetes. I would add in that word appropriate, because in a lot of cases the patients do make insulin, they just don't make enough that has effect. Or in some cases you have a patient that makes too little insulin, or is on the very low end of the range of insulin production, and they're not clinically symptomatic their entire childhood. Because they might live in a home that has very, very great lifestyle practices and dietary choices. Okay, so parents are conscientious about what kind of foods they provide, and it goes unnoticed because there's not a clinical scenario that causes a major problem. Okay? Then the child grows up, goes to college, makes its own choices. Okay? And decides to have like 3 funnel cakes one night for dessert. Okay? And that's just enough to trigger a glucose challenge that causes symptoms. Okay? And they become symptomatic, they end up in the hospital, and usually there's some impetus that stimulates this adult onset of type 1 diabetes in these patients. So they probably made enough, or in addition to that, it wasn't just the 3 funnel cakes. Now their body is 2 times the size it was when they were 6 or 7 years of age, and the relative amount of insulin that they manufacture hasn't changed much. Okay, so the body's larger, the mass is larger, they went through a growth spurt, but then they challenge it with a sugar load, and it causes a trigger of an event. Okay? So type 1 is the inability to produce appropriate levels of insulin. The inability or the lack of an ability to respond to insulin is considered type 2. Now, it also usually is followed by beta cell dysfunction. Remember, the beta islet cells are the cells of the pancreas that actually manufacture the insulin. Okay? Now, we also have what we call gestational. That affects about 3 to 10% of pregnancies. Obviously, it's female specific. There's no cause, no specific cause that's been identified. But it's believed, this is a hypothesis, it's believed that the hormones that are produced during pregnancy make a woman's resistance to insulin higher. And it kind of does survival of the species make sense. So if a woman is carrying an embryo and providing nutrition to the developing child, becoming resistant to insulin a little bit so that there's higher levels of sugar in the blood that ends up getting into the fetal circulation so the fetus can extract the glucose. Right? That's what moms do, right? That's motherhood. So that makes sense physiologically for reproduction or survival of the species. But in these cases of gestational diabetes, it can be overly aggressive to the point of pathological. And now what we see the side effects are is really, really large birth weights of the child. Okay, because the child is getting way too much glucose in their diet. Their diet is mom's blood supply. And mom's blood supply is very, very sugar rich. Okay? If we continue on with diabetes mellitus, just the big family, we're going to kind of combine 1 and 2 here. We can diagnose it or understand when it shows up based on glucose levels in the blood. So normal glucose levels are usually between 70 to 100 milligrams per deciliter. And diabetes mellitus is determined as a level over 200 milligrams per deciliter on a random draw with symptoms. Or there could be a fasting glucose level, meaning you haven't had a meal in about 6 to 8 hours, where there should be down in the 70 range, and their fasting levels are 126 or higher. Or they could do a glucose challenge test, which is a little bit more commonly preferred method nowadays. Okay, so the glucose tolerance or challenge test is a standard dose of glucose is ingested by the mouth, and then we check the blood sugar levels about 2 hours later, just to see how they wax or wane. Okay? So symptoms of diabetes mellitus, symptoms. So we have 3 P's that show up here. The P's that show up here are polydipsia. What was polydipsia? Excessive thirst. Polyphagia, excessive eating. Okay? Polyuria, excessive production of urine. Why excessive eating? Well, if there's too much sugar in the bloodstream, then the cells think that they don't have enough energy. So it stimulates the hypothalamus to say, you should eat a meal, there's not enough sugar. Because the sugar is in the body, but it's not in the cell, it's actually in the blood. Okay? So polydipsia, polyphagia, polyuria. And in weight loss, you're going to see weight loss primarily associated with type 1 diabetes. Okay, type 1 diabetes, unmanaged, of course. And that's because of unmanaged and fluctuating high-low blood sugar levels. So the weight loss is very specific to type 1. You'll see an unmanaged diabetes mellitus, ketoacidosis, which is what was brought up earlier. So ketoacidosis is when you don't have enough glucose to make energy from the cell's going to look for other sources of energy. And so they'll use fats, they'll use proteins, they'll go through ketoacidosis, they'll break down high concentrations of ketone bodies during a metabolic process in order to make energy because you don't have the option of glycolysis. Okay? And so in that situation, one of the byproducts of breaking down fatty acids and amino acids are these ketone bodies that can give off an odor. And so you can smell that on a patient's breath. And a lot of times that is mistaken for somebody actually being drunk. Okay? Now, some of the other aspects of the impacts are going to be here. So we've got lots of non-specific things that take place. In overweight situations, a lot of times this is associated with type 2 diabetes. So you're going to want to write down loss of weight for type 1 diabetes, and here you're going to want to write down overweight or gaining weight with type 2 diabetes. Diabetes mellitus in general, though, are going to see abnormal amounts of lipid, so dyslipidemia, hyperinsulinemia. Hyperinsulinemia, excessive levels of insulin in the blood, that's specific to type 2 diabetes. Right? Because type 1 don't make enough. Hypertension. Hypertension because you have a lot of sugar in the blood, so you retain a lot of water, okay? And that creates excessive blood pressure within the vasculature. Fatigue, because the patients don't have enough sugar inside the cells, so they don't have enough energy. Recurrent infection because of the vascular problems associated with diabetes patients in the periphery. And we're going to talk about that here in a moment. That's what we're going to finish with. And as you lose the ability to perfuse or travel blood to distal extremities, those nerves in the periphery actually start to die. And that's parathesis. That's the early first stages of nerve degeneration, is that pinprick feeling, that needle pinprick feeling. So parathesis kind of goes along with vascular damage issues. Now when we look at type 1 and we look at type 2, there's lots of different ways to treat. And you guys probably you have old notes, you had a whole laundry list of different drugs that we use. So if insulin is a problem, you're not making enough, or if you're not responding to insulin well, we can give you synthetic insulin, or we can give you a form of insulin that's more active. And so for type 1 or type 2 diabetes now, we may prescribe insulin as a therapeutic. Okay, even in type 2. So in fact, you make enough, you make too much, you just don't respond to it. So we might give you some type or form of insulin that you are responsive to. But it's usually an injection, and it's not necessarily commonly to be a pill. Although now some pills are coming out. But why has it historically been an injection and not a pill format? What's that?
So it can go systemic?
Yeah, absorptions of a pill are too slow, and you want systemic delivery quickly. So you give with, a small little insulin needle, very, very tiny gauge. You deliver it really quickly, and you correct insulin levels. So with type 1, you'll deliver injections. With type 2, you may deliver insulin as well. But with type 2, most of the prescriptions are going to be diet modification and exercise. Why diet modification? Well, let's try to curb these large boluses of glucose after a meal that we're not seeming to respond to. In addition, let's look at exercise and the value of exercise. Those of you that are exercise science majors are going to like this one. Okay? So exercise, here is a non-insulin dependent way that you can actually bring in glucose. And that's called the GLUT4 transport protein. So in the absence of insulin, glucose doesn't enter the cell. Okay? Insulin can bind here. When insulin signals the cell, and it inserts the GLUT4 transporter, allowing glucose to enter the cell. Well, the other thing that can happen is in exercise actually upregulates the insertion of GLUT4 transporters into the membrane, independent of insulin. So that's why therapeutically we're prescribing a diet modification and exercise to these patients, because we want more glucose to come into the cell with exercise inserting or upregulating the insertion of GLUT4 transport proteins into the cell membrane. If we don't manage this, in these patients, or the patients don't manage it well. Diabetes mellitus leads to problems known as advanced glycosylated end products, AGEs. So what happens is you get cross-linking of proteins like collagen. And when the collagen protein cross-links because of the high sugar content, you get fat that accumulates. When lipids accumulate on the lining of the blood vessel, that causes a lesion. We'll look at it in the last unit of the semester, and we'll call it atherosclerosis, right? In addition to that, you get plasma proteins that bind to these glycosylated end products. That word glycosylated means that sugar binds to it. It's like a sugar-coated protein now. And these plasma proteins that are circulating around the blood with these sugar-coated proteins, they bind to receptors and they cause all sorts of different effects. So for example, one is activating protein kinase C. What does that do? Well, that causes upregulation of VEGF. That's an angiogenic growth factor. If that happens in tissues that you don't want it to upregulate in, like in the retina, then you get abnormal blood vessel development in the retina, and that's diabetic retinopathy. And that can cause blindness. So you've heard some of the symptoms of diabetes untreated is blindness, nerve paralysis, and chronic foot ulcers, right? So that's where we're headed now. Where does this? So what happens here? Well, this is called the polyol pathway. It looks complicated, but let me just explain it very simply. Here's glucose. Glucose goes through a reduction process to an intermediate known as sorbitol. This is converted to fructose, and now it's really fructose that floats around in the bloodstream and in the extracellular spaces, the interstitial fluid. Because glucose is high in the bloodstream, you're not bringing it into the cell. That fructose increases the osmolarity of the blood or of the interstitium, and water likes to follow. So when water follows where that is, you get swelling and you get cellular disturbances. So you cause tissue damage as a result of this. So having a lot of sugar in the blood coats things. They cause lesions. It causes osmolarity changes. Water follows, and it causes cellular rupture and disturbances. Okay? Now, the three main focuses that we need to hammer home are vascular disease. We covered diabetic. We covered diabetic nephropathy. We need to cover neuropathy in a little bit more detail. But this is showing you all of the vasculature. You have issues that show up in the eye. You can have issues that show up in the vasculature and cause hypertension. You can have issues in the extremities that cause the nerves to be starved of blood flow, and also causes the tissue to be starved. So if they were to be challenged with like an injury, they won't heal very well, right? Because the vasculature also becomes glycosylated. So this is a cross section, and this is a normal blood vessel wall. You see these little thin blood vessels? I would circle some of these. This is actually part of a renal tubule, but this is a blood vessel, this is a blood vessel, this is a, and then these dark ones with these really thick basement membranes, these are all blood vessels as well. But those are all blood vessels that have had AGEs that are attached to them. And now you cause this thickening of that basement membrane. Okay, so that vascular disease that occurs all over the place can help lead to further issues with blindness, in addition to the angiogenesis that's taking place. If this happens at the level of the kidney, then you can't filter, so you get renal failure. If this happens in the distal extremities, and you have a thicker basement membrane, you don't get oxygen transporting across it very well. So you actually get failure of the nerve to receive oxygen. That's where the neuropathies come from. We talked about retinopathies already. Microvascular disease that goes everywhere else. You get the accumulation of the lipids in the vessel wall. That can lead to an increased level of heart infarctions, heart attacks, or strokes if you're talking about the level of the brain. So as we finish it out, the diabetic neuropathy is the nerve damage that takes place as a result of this polyol pathway. High levels of glucose through a reduction process lead to high levels of fructose. That increases osmolarity. You get water following, right, the solutes. You swell the tissue. You cause damage to it. You can cause nerve damage there. In the peripheral distal extremities, the damage that you're causing to the vasculature, these really thick basement membranes, they prevent that transmission of oxygen into a region that is compromised. So in the case of our last picture, I'll dim the light so you can appreciate it well. This is an individual with 2 diabetic foot ulcers. You can see them there pretty clearly. And they're just not going to heal because the high glucose content in the bloodstream is causing these lesions to occur on the vasculature, thickening the basement membrane, or causing atherosclerotic lesions that prevent appropriate blood flow to the distal extremity. In addition to that, glucose on red blood cells, on an RBC, an erythrocyte, actually interferes with oxygen release. So it doesn't come off the red blood cell as readily. So, in summary, glucose levels in the blood being high causes like a dozen problems that I can ask you about. You with me? That's why it's so problematic in our patient population. And whether it's type 1 diabetes or type 2 diabetes, we need to make sure that it's being regulated. Because if it's regulated well, you don't get all of these problems. Questions?